So thank you, Dr. Kumar and Dr. Patyal for this topic, an interesting topic which makes me realize my mistakes, or perhaps the mistakes that we can make in our clinic. So, so if you just have a look at these visual fields, you'll find that on the total deviation plot, there's a marked depression. But fortunately, there is no depression which is evident on the pattern deviation. So I'm sure you'll all agree with me that this patient does not need treatment for glaucoma, right? How many of you agree with that? Yes? So the reason why we think like this and make a mistake is because we do not follow the correct procedure. Automated perimetry provides us with a large amount of data which is quantifiable and reproducible, but the enormity of the data can make interpretation difficult. So there are actually parts to the visual field. Look at the reproducibility, the reliability, the grayscale, the total deviation, the pattern deviation plot, the raw data. Look at the global indices and the glaucoma hemifield test. So if you run through this sequence completely, your clues will be the grayscale, pitch black, a small seeing area. The other clue, the mean deviation is -31, implying that the height of the hill island of vision is significantly reduced. And the other clue is here. The visual acuity is 6/18, corresponding with the foveal threshold of 29. That doesn't make sense. So possibly the patient could have an advanced glaucoma. So this is what it all points to. And if you're thinking in terms of an advanced glaucoma, you would expect changes at the superior pole and the inferior pole of the optic disc. So when you see the optic disc, you find a shallow cupping and you find a splinter hemorrhage present superiorly. So this was a patient with an advanced glaucoma. If you break the sequence and jump just to the pattern deviation to pick up the damage, you're going to miss the glaucoma diagnosis here. So what this patient with advanced glaucoma needed was a 10-2 program so that you could look at fixation and assess change over a period of time. So every time you're looking at glaucoma patients, a 30-degree or a 24-degree field suffices. And if you're looking at advanced glaucomas, it's always good to come back and do a macular program for these patients. So if you're using an octopus printout, now look at this octopus printout. Things are slightly different here. If you jump to the comparisons, which is the same as the total deviation plot, look at the generalized depression you see here. Fortunately, there is no focal loss here. Look at the grayscale, look at the baby's curve. Now, it's important to run through the sequence in your minds, and here there is a small change. Reproducibility and reliability is at the bottom. The grayscale, which points to a small central island of vision here. You take a look at the generalized depression. Fortunately, there's no focal loss. Look at the raw data. The global indices are -26 here, and the baby's curve implies that there's a significant reduction. So again, if you're thinking in terms of a glaucoma change, you would expect changes at the superior pole and the inferior pole of the disc. There are certain clues here. For example, the foveal threshold here is 8, and the visual acuity is 6/60. Could be a patient with advanced glaucoma, could also be a macular involvement because the foveal threshold is significantly reduced. Next step, look at the optic disc. And so we did a macular program, and you found that there was extensive involvement of the central area. We looked at the optic disc and found a normal optic disc. So again, the thought process was look at the macula, and we found that this was a patient who had a traumatic, who had trauma, and there was a macular involvement here which was producing this classical field change. Just a coincidence, every time you see a patient where the fields don't match with the disc or the disc does not match the fields, repeat your clinical examination, look at the optic nerves, imagine that other lesions could also be playing a role. And just a coincidence, this patient followed up in 2010. In 2018, this is how his retina and macula were looking like. So here are the guidelines. Every time you see a printout, for this example, this is a Humphrey single field printout. Look at all parts of the field sequentially. Read the fields sequentially and coherently. If it's an octopus printout, again, follow the parts of the field. Look at all of them before you draw an inference, never the diagnosis. And if you have the Humphrey type printout of the octopus, again, look at all parts of the field before you draw an inference. Correlate the field change with the expected optic disc change. An inferior change in the inferior notch of the optic disc should correspond to a superior hemispherical depression. That inverse correlation should always be kept in mind. So When you when you have a field printout of one eye, this is the right eye, there's a nasal depression extending superior nasally and inferior nasally. But remember, visual fields, both eyes need to be looked at together. Ask in the exam for a field printout of the other eye. So once you're given that, always place the right hand field on the right side and the left hand field on the right side. Now what you will find here is a clear demarcation present here, vertical, implying that you're looking at a neurological lesion and you have an old right PCA infarct confirmed on a MRI. So remember, these steps need to be kept in mind. Any change on the visual fields needs to be correlated clinically. Now when you run through all parts of the field, on the pattern deviation you have a superior hemispherical depression as you see here. If you're thinking in the context of glaucoma, you would expect changes at the inferior pole of the disc. Now here's the disc, normal looking, but it's this patch of choroiditis here which is producing the superior hemispherical change. So always correlate the disc with the fields and the fields with the disc. Remember that any disease of the cornea, something in the anterior chamber, the lens, the pupillary space, vitreous, retina, all can produce a change in the visual fields. So remember to look at these possibilities in mind. If you're looking at a macular disease, then there's always a close correlation, and you can visualize the macular change when you're doing a clinical examination. So any abnormality that you get can be real or it can be an artifact. If it's an artifact of doing, repeat the visual fields and it will go away. So this is a patient who had a lid artifact, the lid was lifted up and the fields repeated, and you found that this has disappeared. So keep this in mind. Visual fields have a definite space in our examination. Don't jump to visual fields for every patient. Make sure you've done a good history, done a slit lamp examination, applanation pressures correlating with the corneal thickness. Make sure you've done the gonioscopy and looked at the optic disc. Then you have a working diagnosis. The next step will be visual fields to corroborate or refute your diagnosis. Imaging devices come only after the visual fields have been done. So this is an example, the last example. One of our patients, every meeting you go to, they say, patients who have ocular hypertension, do a baseline, call them in 6 months to a year's time. So this is what I did. I called a patient with ocular hypertension after 6 months. She came after 1 year, and this is what the field printout was like when the fields were done. Now I've just put this vertically to show you, and this was glaring. I thought I'd make the biggest mistake of my life, calling a person with a normal disc and normal fields, and now this is what I was seeing. While she was waiting, we decided to dilate her eyes. More fields were done. I looked at her previous fields, and this is what it was when she had first come to us. So it was a starer. In the meantime, while she was waiting, 2 or 3 fields were done, and they were all like this, jet black. I went across to the machine, and I found that perhaps in the morning cleaning, the buzzer which is connected to the machine had got disconnected. So fields were being done, patient was responding, but the machine was not recording that effort of the patient, and therefore the fields were being produced like this. 3-4 fields for 3-4 different patients, all had the same change. And when the fields were repeated the correct way with the buzzer injected, the fields became normal. So just to emphasize, do not make a decision based on a single visual field examination. If you have a doubt, please repeat the fields. Thank you very much.